So the title, the subtext of my presentation is From Populations to Persons. And I want to just to express that I'm really trying to talk about how we influence planning for older persons care in Ontario by using clinical knowledge. And when I use clinical knowledge, I know we have a number of people that are here from the community. Your knowledge is also clinical knowledge and quite relevant to system design. So thank you for joining today and for your interest in this topic. I want to also just start off with this quote from Marianne Williamson that you must learn a new way to think before you can master a new way to be. And we're at a time where we actually need new ways to think, and I'm going to try to introduce a couple today. And so think about in what ways can clinicians and older adults collectively prompt different thinking about health services. I'm just going to make that a little smaller here. There we go. And health systems. So my disclosures, I want to let you know that I'm an employee of the Provincial Geriatrics Leadership Office, and this office is hosted by the Regional Geriatric Program of Toronto for the very reason that the Regional Geriatric Program of Toronto is the only independently incorporated specialized geriatric service in the province. And that means that the host for a provincial entity like this is actually very much steeped in this work. I do want to also let you know, though, that the relationship that we have with the RGP of Toronto includes specific terms of reference that allow for independence and autonomy for the provincial office and no undue influence. And I have no conflicts of interest to declare. So I'm going to start off with a quick introduction to the Provincial Geriatrics Leadership Office. You heard Kelly Milne introduce that a little bit in his introduction of me. And then I'll talk a little bit about changing the thinking in health system design. I'll move into tools you can use today that will be useful for both the older adults who are participating today and the caregivers as well as clinicians, and then talk about opportunities to get involved. So what is the PGLO? So in short, this is an office that is intended to provide clinical infrastructure for geriatrics care in the province. It's funded by the Ministry of Health. And so we have specific deliverables that I'll talk a little bit today about that are required by the Ministry of Health. And our office is coordinating perspectives across clinical geriatric services. So that includes care of the elderly primary care physicians, geriatric medicine specialists, geriatric psychiatry specialists, and those who work in seniors' mental health, and as well interprofessional geriatric teams. And the intention is to improve the care of older adults across the continuum of care, regardless of how you come to that work. For those who may have been familiar with the Regional Geriatric Programs of Ontario, the PGLO has assumed the assets. And so some of the work that you see I'll be speaking about today began with the Regional Geriatric Programs of Ontario. That was a network that existed until recently for geriatric medicine-focused services. And we build on that momentum, but broaden the perspective. We're overseen by a provincial steering committee that includes participation from older adults, clinicians, and administrators, and is quite in keeping with the philosophy of experience-based leadership with administrative support. And I think that's really important that this isn't a top-down, but rather a bottom-up approach to leadership for a clinical system. There's dedicated staff, including myself and my colleague Adam Morrison. And then we have two co-medical directors, one drawn from geriatric medicine and the other drawn from geriatric psychiatry for a balanced perspective. We draw on the framework for collective impact. Many organizations are talking about collective impact, and the whole movement towards Ontario health teams is taking up that language, and we provide that backbone support to achieve a common vision. And we have three strategic directions that we're pursuing, and they were established in consultation with the clinical community and older adults. And that includes driving clinical excellence, building capacity across the system, and advancing seniors' health policy. And if you like to tweet, I've put our Twitter handle there for you as well. Just for those who want to situate this work with other types of entities they may be familiar with, if you can see that the provincial office is functioning more at that macro level, doing work around planning and capacity building, clinical model development, performance measurement, knowledge creation and dissemination, as well as policy work. You may be familiar with the work of our colleagues at the regional level, and we're here today at the invitation of the Regional Geriatric Program of Eastern Ontario. And there are like entities and like systems that are located around the province. And at a local level, these regional entities often provide service to individuals and families. They connect closely with primary care, and more recently are supporting the development of Ontario health teams. I want to just highlight this little arrow, this bidirectional arrow, because it'll come up a little bit later in my presentation. So we focus on working together with our colleagues at all levels to collaboratively develop supports. And these are informed by the local and the regional experiences. And so this bidirectional sharing of information. And in short, if all of this is new to you, just think about this. If you're actively providing healthcare to older adults who live with complex health concerns and their caregivers, this is your network. So let's move to changing some thinking and think about how clinical knowledge can help health service design. First, let's start off with frailty as a planning construct. For those of you who may be familiar with the work of the Canadian Frailty Network, older adults living with frailty and their family and friend caregivers need holistic approaches that treat the entire person and health challenges in a coordinated and caring manner. So this won't be new to many of you, but it does have some implications for health service design. And it means we need to change our approach. We need to understand service design for integrated care that work for older people who live with these complex health concerns. And I've used the language of frailty, just picking up on the theme from the Canadian Frailty Network, recognizing that our colleagues who work in seniors' mental health don't necessarily talk the language of frailty. We also have to understand the magnitude of service requirements so that we can really think through the smooth operation of our health system. And I'm going to talk a little bit about magnitude in a moment. What are we trying to accomplish when we think about health service design? Well, we're actually trying to accomplish this comprehensive geriatric assessment, or for my colleagues in seniors mental health, the language may be comprehensive assessment. And this is a bit of a misnomer because assessment kind of leads us down a path of thinking that we're only doing one piece of this puzzle. Well, we don't think that, but others may think that about us. So I just want to remind everybody that when we talk this language of comprehensive geriatric assessment or comprehensive assessment, it's more than an assessment. It's a mechanism for identifying those underlying concerns and developing that holistic approach. And really, we need health system designs that enable us to do this critical clinical function. So when you look at the diagram on the right, you can see all the components of this comprehensive approach to assessment. So it's more than simply diagnostic evaluation. It's all these other pieces of the puzzle as well. And so how do those systems look? Well, when we're designing integrated care for older people with complex and chronic health needs, we did a scoping review of the literature and identified from various frameworks and models of integrated care, 13 core elements that need to be included in design, in health system design for integrated care. And they're reflected here, and I've provided the link to our report. So we've taken up this work as we think about looking across our system. We know that when we look at specialized geriatric services in particular, those services that are focused on, that are clinically focused on older people who live with complex health concerns, we see evidence that specialized geriatric services do many of these elements quite well. And as we move into a health system that's identifying a focus on older people, these are aspects we'd like to see in all health services. I want to talk a little bit about capacity planning and pull back the curtain on how capacity planning happens. What I'm showing you here is from the Ministry of Health's capacity planning guide. And I want to tell you a little bit about how we address each of these areas. So the ministry describes capacity planning as anticipating the magnitude of service requirements by understanding supply, utilization, demand, and need. And supply being the amount of health services available for use, utilization being the amount of health services currently being used, demand being the amount of health services a population wants to use, and need being the amount required. And we're getting at this work through other initiatives that you may have come across. So when we're talking about supply and utilization, we're actively working to collect information about specialized geriatrics programs through our SGS asset mapping initiative. When I say SGS, I mean specialized geriatric services. And when I say that, I mean all services where a certain level of expertise is required in order to serve the population. And that is across the board from geriatric psychiatry to geriatric medicine. So we're collecting this information. Some of you who work in clinical services or administrators in the group today may have been asked to supply some data to our portal, and that's what we're doing when we're trying to understand the supply and utilization. We're collecting it through our asset mapping initiative. We also need to understand the magnitude of need, and we're doing this through some work we've done to estimate frailty by census division, and I'll show you an example in a moment. I want to challenge this idea of demand, and I would suggest that estimation is not required in this case, because I think it's a bit of a myth that older people are asking for health services that they don't need. And I would also say that when we do comprehensive assessment, it means it's really unlikely that people are creating unnecessary demand. So I'm going to ignore demand at this time. I also want to question our current approach to planning, and I find this kind of instructive. On the left-hand side is what's been happening in Ontario with older persons' needs. And this is the estimated population of people over the age 65 who live with frailty, and our own capacity to provide comprehensive geriatric assessment, do that work that I described earlier. You can see that we've had a tremendous growth in the number of people with need and almost a flat line, and I've sort of projected outward if we don't change anything, this is kind of how it will look. On the right-hand side, we have an example that comes from fire services. And you can see in this example that there was an increase in the number of firefighters while there was a decrease in the total number of fires. So that's kind of curious. When the demand for firefighting has declined, we've actually seen more firefighters in contrast to what we're seeing on the left-hand side. So this makes me ask a few questions. When we see other services like fire, police, and EMS that plan for population needs, including uncertainty and complexity, in their definition, uncertainty and complexity are things like distance, density, household composition, traffic congestion, crime, might even include the way houses are built. So other services do plan that way. Unlike health services. And some services plan for latent capacity to enable a response to arising conditions. So when you think about how soon we expect a firefighter to respond to a call, that is part of the planning. And to achieve those response times, there has to be a certain amount of unscheduled time. Health services view unscheduled time as waste. And so we've privileged designs that have very limited capacity to respond to arising conditions. And you can see what's happened, certainly in the COVID example, in locations like long-term care, where we've really enabled or permitted service designs that are very bare bones. And so when a tremendous need increases, we have absolutely no capacity to respond. And so we have examples, not so dramatic, of everyday work outside of the COVID example, of the complex patient who might take longer than the allotted time during an assessment, or the need for an urgently arising home visit. Or this was an example that was given to me of a caregiver who needed relief to attend a dear friend's funeral and absolutely could not get any coverage to support him to have someone look after his wife with dementia while he went to a friend's funeral. And so this seems to me to be sort of in contrast to what we hope for an older adult population living with complexity. And it makes me wonder how we might better align the planning for the nature and magnitude of possible need. One thing we've been doing is actually try to understand the magnitude. And so we've taken the work of Hoover and colleagues who validated a cut point for a frailty index. Really, this is something that can be applied across a population to try to understand how or estimate how many people might be expected to be living with frailty in different population cohorts. So we took this percent distribution value and we applied it to population cohorts from the 2016 census, and we projected out to 2040. And we did this at the census division level, so it'd be useful in Ontario Health Team planning. That's just a little bit more. We went right down to the census division, and then we produced things like this. And so this is available on our website. And here's an example from Frontenac, where we've taken the available data and we've estimated the population living with frailty in that community. So by 2040, we can expect that 14,000 people within the population of Frontenac may be living with frailty and require health services specifically designed for their needs. What are the planning implications of this? Let me go back to that capacity planning diagram. And don't worry if you're starting to drift. I'll tell you why this is relevant to you in a moment. So just I'll just ask you to imagine for a moment, and I have some good familiarity with Northumberland County. So let's just put the pieces of the puzzle together. In Northumberland County, I'm aware of the supply and utilization of existing health services that are specifically focused for older people living with complexity. We have one primary care memory clinic. In that case, it's called a MINT clinic. We have two geriatric community teams called GAIN teams, and we have one GEM nurse in that community. And the utilization is reflected by their service use. So I've listed the visits there. And we've estimated the need. We know that there's an estimated 6,000 people living with frailty. Now, when you think about effective follow-up and follow-through, how much service or care does a population of 6,000 older people with frailty need? And I've just, you'll see the little notes underneath there. If you think about follow-up and follow-through for frail people, they may need up to 4 to 6 visits annually. And I'm not specifying what kind of visit, which quickly adds up. And you can see that takes us to almost 24,000 to 37,000 visits, just to make sure that they're getting the care that they need. And I say that from experience. Our community teams certainly had that experience when I was working in this area. But I also think about, when we think about other complex conditions, we have standards for follow-up and follow-through for people who live with diabetes, for example, and that there's an expectation that they'll be seen 4 times a year in follow-up for their diabetes. And so a person who might be living with multiple comorbidities, I would expect no less. So that's sort of how that estimate comes. So kinds of considerations here on the right-hand side are, to what extent should all people living with frailty in your community have access to specialized geriatric services? At the current level, and in this example, it's 15 to 25% coverage of the total population. What are the indications of unmet need? Are you finding in your community that there's a lot of frequent emergency room visits? Are there long wait lists for specialized services? Are there increased requests for primary care? These are all planning questions that could be asked while you're sitting at the table with others who may be planning services for older adults. What are the downstream indications of needs left unaddressed? What's the alternate level of care rate? What do the long-term care wait lists look like? What do the home and community care wait lists look like? And what about assisted living? And are there excess deaths in your community? What about the growing numbers of primary care growing numbers of individuals that primary care providers are worried about? When I was part of planning for local OHTs, Ontario Health Teams, this was a question that we used as an indicator of how to identify a population that we wanted to serve. Simply asking primary care providers who you're worried about. I think they have a good sense of the people that they think need special attention. And are there upward trends and less obvious indications of need? We're hearing about increased requests for medical assistance in dying, where there may be increased police reports of elder abuse. There may be something that I've just colloquially termed gem sense here, that the people that are turning up in the emergency department that are being called failure to thrive or failure to cope, or perhaps they're older persons who've been abandoned by their family in the emergency department. So what's happening that also tells you that what you're planning for may not be quite right. And this is what it looks like when you model this through. So I know it looks like a lot of math at the moment, but let me just walk you through it, because I think it's important for people who work on the front lines and older people themselves to understand the thinking. So in this example, if we only wanted to serve up to 25% of the population, we have enough people. We've got 11.5 FTEs, and we have enough if we only want to offer 4 visits a year. But if we wanted to have 100% of this frail population served in what we think is the best standard, we'd need to offer between 26,000 and 39,000 visits a year. And how do we do that? How do we have between 48 and 72 full-time equivalents paying attention to this population? So that might mean we might have to create new partnerships. We might have to spread the knowledge from the specialized geriatrics community to others. We might have to get other people excited and interested in providing care to this population. So these are questions for you to take to the tables where you're participating in planning. What's the level of service do you want to plan for? What evidence or experience is there out there? And, what's the harm of overestimating? I think that's a fear that it's wasteful. I really think if we overestimated, could we be fluid in our model to redeploy temporarily as needed? I can imagine a scenario, this is exactly what's happened with community paramedicine in locations where the demand for paramedics to be in trucks responding to calls on all the time meant that there was some latent capacity. And I can think of a concrete example in the community in Halliburton when I worked to help establish a community paramedicine program. They had downtime, and that meant that they could even contemplate doing things like community paramedicine. So could we do the same thing? Could we staff teams to be available to respond in a more urgent fashion, or to do ad hoc wellness checks if there happen to be no scheduled in-clinic appointments? So just starting to think about things like that. I'll just ask you to stick with me for another couple of minutes, and then I'll move on to things that are right at the level of practice for you. So let's also because I think it's helpful to understand the magnitude. So when we think about dementia cases, I'm going to give you an example from the Southwest, Lynn. When we think about the work that's been done to estimate the incidence of dementia, how do we turn that kind of information into something useful? So what I've done here is I've imagined if each person who's diagnosed with dementia requires a reassessment visit every 6 months, and that comes from the Ontario Health Quality Dementia Standard that says a person living with dementia should receive a comprehensive assessment every 6 to 12 months. From the clinical experience that I've seen so far, I would suggest that we would want to plan for 6 months, especially in the early years, because there's maybe a level of uncertainty, or maybe at all times. So if you do the math and you assume that people may survive at least 10 years following a diagnosis, then in the Southwest Lynn alone, this community will need a capacity of about 50,000 visits per year to meet the standard of care for people living with dementia. So I think it's really important to understand magnitude. And now just finally, this is my last capacity planning slide for you, just getting into the weeds of needs. Because I think there's lots of math out there, but I think this is where the clinical and personal experience really makes a difference. It's not enough to know how many people might be expected to be living with a particular health concern. How many people have COPD, CHF, congestive heart failure. We also need to translate our clinical and older person's experience into complexity-sensitive design. And that means, for example, if you going back to the dementia example, we have to understand the requirements of people at different stages of their condition. And so what I'm showing here comes from some consultations I did in 2014, where older people and clinicians sat together and sort of imagined the kinds of things they needed, or not imagined, they reported on the kinds of things they needed in the early, middle, and later stages of dementia. And those are many of those activities are different and require different kinds of health services. And knowing that means that we can offer really solid advice around designing flexible services that can produce the outcomes people want. Once you answer some of those questions, there's all kinds of geriatric service design options. This is the information we've culled from our SGS asset mapping project. These are the types of services that are available right now, and these can be leveraged to create new models. I mean, we're already hearing about new and innovative models. Some of these types of services could be integrated with each other and with other kinds of services, like the embedding of community paramedicine in geriatric outreach teams. So why is this all important? Thank you for bearing with me. Why would you want to know this? You want to know this because you have unique information about a population for whom the healthcare system is not designed. And you actually have the answers to what can we do and how do we do it, that so many people are asking. These are questions that are being asked by Ontario health teams. And many Ontario health teams have identified older adults as a population of focus. So you actually have those answers. Clinicians and older people, clinicians working in geriatric services can inform and contribute to the work of Ontario health teams and other kinds of entities that are purporting to serve older adults. And you can inform the development of tools and resources just by sharing your observations, your challenges, and your ideas. And I'll tell you, you already have. So let's move to the tangible tools you could use today. And yes, it was your experience and involvement that informed their development. So the first I'll just share with you is supports for caregivers, caregiving strategies. This is a series of handbooks and an online course and various tools that support caregivers in various topical areas like understanding dementia, understanding delirium, staying active, nutrition, pain, medication, bladder health, and social engagement. These resources were co-designed by caregivers and healthcare experts, and these are the topics that are covered. And this is I've got links in here to the website so you can find them yourself, and you can dive right in and understand. You can print off the materials, or you can follow along in an online course that's free. And the Caregiving Strategies Handbook is available in 4 languages. Another tool that you can use that was also developed by the clinical community is the competency framework. So when we first set out to, the reason or the genesis of this work, this came about because we observed that members of the interprofessional team who were coming into specialized geriatric services didn't have a good sense of what they were being asked to do. And when you think about the chronic disease management model, there's a component of the chronic disease management model that speaks to prepared, proactive teams. And so members of the interprofessional team really needed to understand their role within the comprehensive geriatric assessment and how they participated, so that they were offering their best contribution to that overall piece of work that I pointed out earlier. And so we worked together to identify behavioral statements that would describe the practice expectations for the members of the interprofessional team. And this is the interprofessional team that would work in concert with physicians and others. And so we developed this competency framework. It was developed collaboratively with colleagues across the province. And at the same time, we also developed a complementary self-assessment tool that would allow practitioners to look at themselves and evaluate where they had learning needs. And once they identified learning needs, we also created a compendium of educational offerings that were relevant to their practice and to understanding specific discrete elements of practice in this area. And this is what it looks like on your phone. And I'll just sort of walk you through what you're seeing here. So if you've identified you have a need to learn more within core geriatric knowledge, maybe you need to understand more about normal aging. It's not something that you covered in your basic program and in your health professional preparation. If you could dive a little deeper into the category of normal aging, and you'll find a series of resources there that you can access. And in this section, they're free. And as well, we're also being responsive to emerging issues. And I'm proud to say, if you look at the names of this particular publication, Dr. Frank Milner is well known to the Champlain group. Dr. Sophia Benjamin is the co-medical director of the PGLO. Stacey Hawkins and Melanie Briscoe and Sabine Hassan are all from several of the specialized geriatric services. Stacey and Sabine from Seniors Care Network, and Melanie from the Northeast Specialist Geriatric Service. So here's an example of clinicians identifying an emerging clinical issue and then coming together to respond to it and develop high quality evidence that can support practice for everyone. This particular piece of work came about because of the monetization of a commonly used clinical screening tool. And this is part of two aspects that are emerging. One is addressing specifically cognitive screening tools, and the second, cognitive assessment tools, and there's a difference between the two. So this article came out first, and then the cognitive screening toolkit has just been published through the American Geriatric Society with some of the same authors. And this is what that looks like. If it requires free registration, but it does give a summary of several tools that are suitable in primary care. And when you click on it, it gives you, you can see a little filter has shown up here on the screen, allows you to pick tools by various filters. And then when you click on a specific tool, it tells you all about the tool, and then it launches into the tool. And these are all the tools that are freely available and could be used largely in primary care practices. Some other work back to the SGS Asset Mapping Initiative. So when I spoke about the work that you've been contributing to when you're providing your program data, this is how it's being used. In our first pass at this, when we collected 17-18 data, we produced 3 reports that are all available for you to take a look at. The 2 on the left speak to physician human resources and in the geriatric medicine, geriatric psychiatry, and care of the elderly domains. And the center report goes into a little bit further detail and to speak about the various features of people living with dementia and frailty and the utilization of physician services. The report on the right is a comprehensive report of all 26 types of geriatric services in the province. It includes descriptions of those services that you helped to fill out and definitions. So the features of the various services are described, as are the statistical information and location of those services. So that one's quite a long report, and we're going to be producing another version of that when we have concluded data collection for this year. So that's in progress. Some of you are participating in that, and I know that Kelly Milne and his team have been really helping to consolidate data from the Champlain area, as are others on the call. And finally, from a COVID perspective, we also assisted in compiling information for the field. In the early days, we were able to get out a clinical screening, telephone screening tool that was taken up in many programs within days of lockdown back in March. And we also have been curating a searchable list of clinical resources as they're brought to our attention. We provided advice early on by convening experts from across Canada to discourage the inappropriate use of the clinical frailty scale, which would have prevented access to critical care for older adults at too low a level. And so we were able to combat that incorrect application of the clinical frailty scale. And we've also, in collaboration with our colleagues at the Canadian Geriatric Society, we've convened and maintained 3 sector-specific groups, one focused on issues pertinent to long-term care, a second in retirement homes, and a third in in-home and ambulatory care. We've also consolidated expert advice nationally to create a statement on family presence in long-term care, and that came out in June and preceded changes in policy that occurred at the provincial level. We prepared a couple of just-in-time webinars, and a international town hall related to long-term care. Most recently, we've prepared some resources to support vaccine uptake in older adults, and that includes Mythbusters and with a video and some clinical information to help people overcome hesitancy. So take a look at those if they're of interest to you. Finally, I'll just move to getting involved. So we have several opportunities to help grow our network together. And these are sort of in decreasing level of commitment. You could certainly join a committee, although during these times people have many other priorities, and that may be difficult. You can participate in a project. You can help us develop and participate in communities of practice. You can always attend a webinar or a town hall event, and those are interactive events where we'll be seeking your input. You can get on our stakeholder list, or quite frankly, you can send a random idea. I've had some very successful random ideas sent in that have actually influenced change, and I'll give you a concrete example. When I was running community geriatrics teams in a region that I was working in, I got a call one day from a person who was standing, at the time our referrals were only from a family physician or through the emergency department. And I got a call from a community worker who was standing in the home of an older person who was clearly in need of assistance from geriatric services. And this worker challenged me and said, if I know we're trying to avoid sending people to the emergency department, but this person doesn't have a family doctor and they really need the assistance of your team. We need to change the route of entry into your system. And so we did. We actually started to allow for self and community referral. So I just wanted to share our engagement structure, and it's purposefully non-hierarchical. We have different ways that people are becoming involved with this network, and those that are in italics are still yet to be fully developed, but opportunities. So I just wanted you to be aware of what kind of topics are bubbling to the surface, and look at perhaps ways that you might be able to get involved. And this is a particular project opportunity that's sort of hot off the hopper that I'd like to tell you about. We're leading the development of an indicator set for older persons. This is intended to bring together older people, caregivers, health professionals, researchers, and policymakers to create a performance measurement framework, indicators, and data collection tools that are relevant to integrated care for older persons. This will support the collection of consistent, measurable, reliable, and valid data across our specialized geriatric services, Ontario health teams, and others. And we're interested in inviting people who'd like to become involved. One way that you can get involved is to be part of the stakeholder advisory group. There is a bit of an intensive but short duration time commitment here. We're looking for people to participate in a research process, which is called a Delphi process, where you would evaluate in 3 successive rounds. We expect to have 3 successive rounds, a series of indicators. We've done the work to scour the world really for indicators that speak to integrated older persons care, and we now need to go through the process of narrowing down that list with expert opinions. So if you're interested in that, do feel free to reach out to me. We'd be starting in early March and ending at the end of April and the beginning of May. So bit intensive. It doesn't have to happen it would be sort of an asynchronous process, so you don't have to be in a meeting to participate, but that's something to watch for. Finally, I'd also just want to raise the awareness of some work we're trying to do to build communities of practice. And this is where, if you just want to take a moment and offer your thoughts in the chat, I'd like to grab those from you. We're beginning to think about convening province-wide communities of practice. This could be an added support to existing groups like GEM nurses who've had a network for some time and may need some infrastructure for that to continue. It could also be a new platform for emergent groups and themes. So I'm welcoming your ideas at this time. So in the chat, feel free to list themes or ideas that you think would be of value to create communities of practice around. And the plans would be to link to or drive ongoing educational activities, such as some case-based learning that we're developing, some education days, as well as develop resources and tools like you've seen examples presented already. So really, in summary, we're actively supporting those strategic directions of clinical excellence, capacity planning and building, seniors health policy development. I've pulled back the curtain a little bit, maybe taking you places that you don't normally go, but showing you how things work. And I'm happy to take some questions now and talk a little bit further with you. Thank you.
Thanks so much, Kelly, for that great oversight of the Provincial Geriatric Leadership Office and some of the work you're doing to try to build system capacity, local capacity for older adults and their caregivers. So maybe we'll just look, I'm just looking in the chat room. I don't see any questions at this point, but are there any questions from the audience? I'm wondering with the asset mapping exercise that you're proceeding with kind of in your kind of second phase of that with 1819, 1920 data, what maybe are some of the outcomes you're hoping to achieve when that actually starts to be analyzed and kind of looking at what the next steps in the evolution of that asset mapping exercise would be?
Mm-hmm. Thank you for that. So I think that the first intention would be to provide information back to those who've sent it in, along with information about the magnitude of anticipated need, so that you have planning information that sort of brings together in one place a picture of what's available and to be leveraged and what may be needed in your region. The other thing that I think we can use that information together collectively is to start to ask questions about what are core ways of doing the work. Right now we have 26 different definitions or defined types of services. Are there ways that we could think about amongst ourselves, higher levels of integration, higher degrees of integration? What would that look like? Are there services that could be highlighted or ways of going about the work of older persons care that we really want to focus on? I think it does allow us to have that opportunity to understand our own system in a way that could allow us to standardize more or develop clinical models that we think are optimal. So I think what's important to remember about this is the exercise is not a reporting exercise to the ministry. It is a survey exercise, a census exercise that's useful for planning for the community of geriatrics, as well as the broader healthcare system. So if for those that may be contributing and feeling a little bit like it's Big Brother watching you, it's not the intention at all. It's really a collaborative effort.
Super. And I noticed we have a couple things from the chat room, Kelly. So the first is from Dr. Alan Wong, asking about how about adding a pharmacist rep since older people consume many medications?
Thank you. And I'm not sure the context for the question. Were you talking about like where were you thinking that representative would be added, Dr. Wang?
Oh, thanks, Kelly. It's on at several levels, because if we want to detect problems with older people in the community before they happen, a pharmacist can be a very useful ally. And detecting changes, if you're looking at people on the frailty scale, because all our older people are going to pharmacies on a regular basis, and it's an essential service, etc. But it's data that doesn't really fold in anywhere other than day-to-day operations at a pharmacy.
Mm-hmm. Thank you for that. I think that's an opportunity for that might be first off in the indicators work to make sure that we have that perspective as we look at indicators that might be important to have in an indicator set. I also think that that might be an example where, and this had been some experience I've had previously when I was hosting communities of practice at a regional level. We had a community of practice that included clinical pharmacists involved with geriatric services. And the hook that we had for communities of practice was that they had to offer their advice back to the overall system. So it wasn't just to talk only about pharmacy related issues amongst themselves, but instead to offer pharmacy input into how the overall system ought to be organized. And that was very rich and important because it meant that other people took up the advice and knowledge of pharmacy into the overall work of the interprofessional team. So I agree with you. I think that we would want to make sure that we hear from pharmacists in a number of different ways. We actually have enabled members of the interprofessional team in the design of our steering committee. We have, at the moment, we have physicians and administrators and older adults, but the administrators come from a perspective of hosts or being in charge of or leading in interprofessional teams that include pharmacists. So we also haven't excluded that down the road that those positions might actually be held by some of those clinicians that who themselves have system level perspectives. So thank you for that. I think it's important that we make sure that we hear and it infuses the work throughout. But if you have a colleague that you'd like to recommend for the Indicators Project, that would be a great first stop.
And there, another comment from Cheryl in reference to your communities of practice. The Nurse Practitioner Association of Ontario has a community of practice for long-term care for nurse practitioners to help share information and identify challenges and successes. So that might be an opportunity maybe to link up, or you may already be linked up with that group, Kelly?
I know that a number of the nurse practitioners that work in geriatric services are part and parcel of NPAO, or members of NPAO. So I think some of those connections may be forged as nurse practitioners themselves from specialty geriatrics themselves identify a desire for a community of practice. I also know that I also have an upcoming meeting with the provincial representative for the NLOT group, which are nurse practitioners working in long-term care as well as in other settings. So there may be some crossover, and we'll watch for that. Thank you for the comment.
Super. And just a comment from Heather McLeod, just looking forward to the further development of the communities of practice, and recognizes that there's been a fair bit of that work across the province and across the country.
Thank you for that. Thank you. And Heather, I just want to give a shout out to Heather, actually. Heather's an awesome example of a frontline clinician who wears many hats, and her experience has been influential. She's been a longstanding member of the Comprehensive Geriatric Assessment Knowledge to Action Committee. In fact, we'll be leaving this forum and going to that together in just about a half an hour. And there's a perfect example of a person who has frontline experience that's been influential at a provincial level from the get-go. So anyone who's working at the front line, don't think that your voice doesn't matter.
Thanks again, Kelly, for a very interesting and descriptive presentation on the kind of the work that your provincial office is doing in terms of building that necessary capacity for older adults, especially as a result of COVID and the challenges it's imposed on older adults across our system of care.